If the function of the respiratory system is interrupted, then there will be consequences on the partial pressure of gases, because that is the main function of the respiratory system, to ensure that the partial pressure of oxygen and the partial pressure of carbon dioxide is maintained normally in the blood levels. So in case of respiratory failure, there can be hypoxia, that is partial pressure of oxygen less than 60 millimeter mercury. So this is basically hypoxemic hypoxia. Hypoxemic hypoxia where partial pressure of the oxygen is decreased. And there can be hypercapnia where there is increase in partial pressure of carbon dioxide which becomes greater than 45 millimeter mercury, which is the normal level. Actually it can become greater than even 50 millimeter mercury. So that is hypercapnia or hypercarbia. Now based on whether there is a decrease in partial pressure of oxygen only or there is presence of hypercapnia as well, we have two types of respiratory failure. Type 1 respiratory failure where there is only hypoxia, and type 2 respiratory failure, type 2 meaning both are happening. There is hypoxia as well as hypercapnia. So, before going into the causes, let us see the basic fundamentals of physiology so as to understand the causes and the consequences better. So, this schematic diagram is showing the basic action of respiratory system. Respiratory system, there is inhalation of gases from the atmosphere. So, that gives us the fraction of inspired oxygen, which normally at sea level is 21%. If we go to high altitude, then total atmospheric pressure decreases from 760 millimeter mercury. Okay, while the percentage of oxygen which is there, that is 21% only. However, the atmospheric pressure decreases from 760 to lesser. So that means the inhaled partial pressure of oxygen, ultimately the alveolar partial pressure of oxygen will be affected. So FiO2 is normal at high altitude, but total atmospheric pressure is decreased. But there might be certain conditions in which FiO2 also is decreased. For example, in a closed room, if smoke is filled up, then in that case FiO2 will be lesser. Then ventilation is occurring, that means taking in of air and moving out of air. That is important, that every time we inhale and exhale, fresh air is brought in, and the air where the gas exchange is already taken up, that air is exhaled out. So that is ventilation. Then at the level of the alveoli, there should be proper ventilation perfusion matching. The alveoli should be ventilated and there should be proper blood flow to the alveoli so that the gases can diffuse. Then diffusion should be proper. So even if ventilation perfusion matching is there, there might be conditions in which the diffusion is affected. For example, if there is thickening here, okay, then what will happen? The distance across which the gases have to cross, that increases. Or suppose there is collection of fluid, some collection of fluid in the alveoli, then also that distance is increasing. So diffusion should also be proper. And then finally the blood flow to the lungs from the right ventricle should occur. It should not be that directly from right ventricle the blood is going to the left side of the heart, or from right atrium it is going to the left side of the heart. So that should not happen. The blood should go to the lungs as well for proper diffusion of gases to occur. So based on this concept, now we will see what are the causes of type 1 respiratory failure, that is the causes in which hypoxia is going to occur, and type 2 respiratory failure, that is the causes in which both are going to occur. So first we will discuss about type 1 respiratory failure. So here it is showing the causes of type 1 respiratory failure, where it can occur with all the causes. The problem is in all the causes. Yes, decrease in ventilation, it is in early stage it leads to only hypoxia, but in later stages it leads to hypercapnia also. So hypoventilation causes hypoxia as well as hypercapnia in later stages. So we will see this hypoventilation mainly in case of type 2 respiratory failure. But remember, in early cases there is only type 1 respiratory failure, that is the hypoxia developing. So in all cases there can be type 1 respiratory failure leading to hypoxia. And why is this that all these causes lead only to hypoxia and not to hypercapnia? That is because of fundamental concept that diffusion of carbon dioxide is 20 times faster than that of oxygen. So to understand this, you can watch my video on diffusion of gases in respiratory physiology. But fundamental here is that diffusion of gases is 20 times faster. So suppose if there is ventilation perfusion mismatch or if there is diffusion defect, then first thing which will be affected is oxygen transfer. Okay, it is not carbon dioxide transfer, because wherever the alveoli in normal, suppose ventilation perfusion match, say suppose here it is normal and this side it is abnormal, say suppose some block is there, then the compensatory changes are going to take place, mainly increase in the respiratory rate. Because if gases are not becoming normal, say suppose hypoxia is occurring, then compensatory there will be increase in the respiratory rate. So there will be increased ventilation in other normal alveoli. So because of this increased ventilation, whatever carbon dioxide is accumulated, that can be thrown out. Okay. So that is why hypercarbia doesn't occur in other causes. Only in hypoventilation it will occur, because in that compensatory mechanisms are not going to occur and hypoventilation itself is occurring. So carbon dioxide cannot be thrown out. Okay. So let us see what are these causes of type 1 respiratory failure and how they are going to lead to hypoxia. So one is alveolar hypoventilation in initial stages. Say suppose this is the alveoli and this is the blood vessel. If less air is going inside, okay, alveolar ventilation is less. If less air is going inside, then obviously less oxygen diffusion is going to take place, right? But if it is not that severe, maybe in some alveoli there is hypoventilation, in some alveoli it is not, then in that cases carbon dioxide can diffuse. Okay. Then next is diffusion defect. Say suppose there is interstitial lung disease. In interstitial lung disease there is thickening of the interstitial tissue. Okay. Interstitial lung disease leads to thickening of the interstitial tissue. So this increases the diffusion distance. And what will be affected? It is basically the oxygen diffusion which will be affected. Carbon dioxide diffusion, see, it is 20 times faster. Okay. So even with some problem, carbon dioxide can diffuse. So we don't get hypercarbia or hypercapnia in case of diffusion defect. So one is interstitial lung disease. Other cause is emphysema. In emphysema, what is happening? In emphysema, there is decrease in the surface area of the alveoli. See, for diffusion to occur, what things are important? Area of the diffusion membrane is important. Diffusion is directly proportional to the area of the membrane and inversely proportional to the thickness of the membrane. So when thickness is increasing, diffusion is decreasing, and when area is decreasing, then also diffusion is decreasing, right? So in emphysema, because these alveoli, there is breakdown of the septa between the alveoli, so they coalesce, thus forming one big mass and decreasing the surface area for the exchange of the gases. So that is why the diffusion of oxygen is affected, causing hypoxia and type 1 respiratory failure. Next cause is VQ mismatch. VQ mismatch is basically when there is a mismatch between the ventilation and perfusion. Normal ventilation perfusion ratio is 0.8. Again, I encourage you to watch my video on ventilation perfusion ratio, very fundamental. Why? Because this ventilation perfusion mismatch is the most common cause of type 1 respiratory failure. In fact, any disease, any respiratory disease causes some amount of ventilation perfusion mismatch. So here we have certain examples where in the first case you see perfusion is decreasing, right? Because of some blockage, maybe some embolus is there, it is causing decrease in the perfusion. However, ventilation is happening. Okay, so ventilation is normal, but wherever ventilation is occurring, because of decreased perfusion, the gases which are there in the alveoli, they cannot diffuse because blood flow is not coming, so they cannot diffuse. Hence this is known as dead space ventilation. What can be the causes? They can be pulmonary embolus. So in pulmonary embolus there will be blockage in the vessel. Okay, so that is dead space ventilation. Next one is shunt. In shunt what happens? Ventilation is decreased. Okay, so with decreased ventilation, blood flow is normal, air is not going to particular alveoli, so that is going to cause ventilation perfusion mismatch. So even if blood flow is occurring, the partial pressure of gases in the blood are not changing. It will be just like that of deoxygenated blood, right? So oxygen will remain less and carbon dioxide will remain more, and ultimately they will club together, they will join from the area where there is normal ventilation perfusion. So that blood will join with the blood with abnormal ventilation perfusion ratio, and what will happen? See here, PO2 is less, it is 40 millimeter mercury, and in other side PO2 is 100 millimeter mercury after proper exchange of gases has taken place. So when they combine together, ultimately the PO2 is going to be less. Again, hypercapnia will not occur because of the compensatory changes. So wherever BP matching is there, because of increased ventilation, carbon dioxide will be thrown out. However, remember one thing here, that if there is extreme ventilation perfusion mismatch, that occurs in some cases, like there is extreme atelectasis of the lung, like complete atelectasis of the lung. So there is collapse of the alveoli. Then in that case, it will lead to hypoventilation also, and that is going to affect the carbon dioxide transfer also. So remember this VQ mismatch. Mostly we are telling that most common cause of type 1 respiratory failure. But when it ultimately leads to extreme hypoventilation, like the worst case scenarios, in that case there will be alveolar hypoventilation and it will lead to type 2 respiratory failure. Moving on to the next cause, that is the right to left shunt. So in BQ mismatch also there is right to left shunt. See, we have named here as shunt, but this is intrapulmonary shunt. Intrapulmonary shunt, and that is occurring because of the accumulation of fluid in alveoli, as in pulmonary edema or maybe pulmonary hemorrhage also. So there is accumulation of blood in the alveoli, that is going to cause the shunt, that is intrapulmonary shunt. But there might be extrapulmonary shunt also, where there is movement of blood directly from right side of the heart to left side of the heart. Okay, so these occur in some cases of congenital heart diseases, where movement occurs from right side, that is the deoxygenated blood moves to the left side without getting oxygenated in the lungs. So that is also going to cause hypoxia. So that was the type 1 respiratory failure. In summary, any wear problem will cause type 1 respiratory failure, but alveolar hypoventilation, in severe cases, it will lead to type 2 respiratory failure. So let us move into type 2 respiratory failure and try to understand it conceptually. So here I talked about respiratory failure, and you see in type 2 respiratory failure I have written one equation where partial pressure of arterial carbon dioxide is equal to the volume of the carbon dioxide which is produced in the body per unit time divided by the alveolar ventilation. Okay, so in simple terms it means if carbon dioxide is produced more in the body, then the arterial carbon dioxide is going to increase. Second thing, if alveolar ventilation decreases, then also partial pressure of carbon dioxide is going to increase. More the alveolar ventilation, there will be more diffusion of carbon dioxide and it will move out. Okay, so this equation tells us that what will be the causes of increased arterial carbon dioxide, that is hypercapnia. And let us see one more equation here. So you see here, alveolar ventilation is equal to respiratory rate multiplied by amount of air which is going into the alveoli with each breath. So tidal volume minus the dead space volume. So this is the amount of air which goes into the alveoli with each breath. Okay. So what it says is that if dead space ventilation increases, that PQ mismatch we were talking, that if dead space ventilation increases, then this value is going to decrease. See, initially it will be compensated by increase in respiratory rate. So alveolar ventilation is going to be normal. But later on, maybe the dead space ventilation, if it is too much and respiratory rate is not able to compensate, then this alveolar ventilation is going to decrease. So by understanding this equation, you will get to know that yes, what are the things that will affect alveolar ventilation, and if alveolar ventilation decreases, then arterial carbon dioxide is going to increase. So one is that increase in dead space ventilation, and other very important is decrease in the respiratory rate. So if respiratory rate decreases, then also alveolar ventilation decreases. If VD increases, then also alveolar ventilation is going to decrease. Okay. So with this, let us see the causes of type 2 respiratory failure. So causes of type 2 respiratory failure are broadly classified into won't breathe and can't breathe. Won't breathe means that there is no respiratory drive for ventilation. Okay, so there is impaired CNS drive to breathe. See, in the medulla we have neural centers which govern the respiration. We have the dorsal respiratory group, ventral respiratory group. You can again watch my video on neural regulation of respiration to understand this. If these centers are working less, if there is suppression of the medulla, because these centers are located in the medulla, if there is suppression of the medullary function, then there will be decrease in the CNS drive to breathe. And the causes include drug overdose, basically the opioids overdose, benzodiazepines overdose, brainstem injury, because medulla will be affected, neural centers are located there, sleep disordered breathing, severe hypothyroidism, there is decrease in the metabolism, there is impaired CNS drive to breathe, and the infections or tumor which affect the brain and ultimately the working of the medullary center. So that is won't breathe. In simple terms, impaired CNS drive to breathe. Okay. Moving on to the can't breathe, that there is a drive but there is some problem in the local apparatus. So we have to understand the mechanism of breathing to understand the can't breathe causes. See, for breathing, we want our muscles, respiratory muscles to contract. Respiratory muscles should contract, and there should be proper functioning of the lungs also and airways also. Why? Muscles will contract and cause the expansion of the lung. But suppose the lung is totally collapsed, alveoli are totally collapsed, then the lung compliance is too less. The lung is not going to expand. So in that case, there will be no expansion of the lung. So that will cause the hypoventilation. Similarly, airways. When the muscles are working to cause the expansion of the lungs, there is some pressure difference between the atmosphere and the alveoli. Okay, so here there is atmospheric pressure and here we have the alveolar pressure. Now, if there is excessive blockage in the respiratory passages, then this pressure difference between the atmosphere and alveoli may not be enough to cause the movement of the gases. So in that case, muscles have to work more so as to cause much decrease in the alveolar pressure. So they increase the delta P, that is the pressure gradient for the movement of the gas, and then only the air is going to move. So what is happening? Respiratory muscles are working too much. Ultimately, they are going to get fatigued. And similar is the case with the decrease in compliance. Respiratory muscles have to work too much. So that means all these diseases are increasing the work of breathing as well. Okay, work of breathing as well, and that is going to ultimately lead to the fatigue of the muscles. They can't contract indefinitely at such a great force. Okay. So with this concept, let us see what will be the causes of can't breathe of type 2 respiratory failure. So in can't breathe, we have impaired muscle contraction, in which we have the problem of neuromuscular junction, that is the myasthenia gravis. We have the problem of the nerves, that is amyotrophic lateral sclerosis, Guillain-Barré syndrome, where the impulses will not travel via the nerves to the respiratory muscles. And then we have the problems in the muscle itself. Suppose there is myopathy, or there are electrolyte imbalances as well, because electrolyte imbalance affects the action potential generation, which in turn is responsible for the contraction of the muscle. The next causes increased load on RS, such that it is going to increase the work of breathing. I will again encourage you to watch my video on work of breathing to understand this concept. So what are the causes which increase the work of breathing? We have the causes where there is decrease in lung compliance, and there are causes in which there is increase in resistance. So increase in resistance happens in chronic obstructive pulmonary disease, bronchiectasis. See, initially in COPD there is hypoxia only, but in later stages there will be hypercapnia, as there will be hyperinflation. Both COPD and bronchiectasis cause hyperinflation. So with hyperinflation, much of the air remains in the lungs itself. It is not moving out. So I told you, what is ventilation? Ventilation is bringing in of air and going out of the air. So if the air is not able to go out, that means fresh air is not coming. That much amount of air cannot come, because the lungs are almost full to its capacity. So that is why there is decrease in ventilation. And what are the causes in which there is decrease in compliance? We have alveolar edema. I told you before also that alveolar edema, it is leading to VQ mismatch as well. In fact, most of the respiratory diseases lead to VQ mismatch. But if this alveolar edema is severe, most of the alveoli are affected, then it will cause hypoventilation also, and it is increasing the work of breathing as well, because the lung compliance is decreasing. So alveolar edema, atelectasis, then chest wall abnormalities as well, like kyphoscoliosis. So lungs are not going to expand properly. For expansion, we need the proper apparatus, that is the chest wall, the rib cage, they should expand properly, right? So kyphoscoliosis is going to affect extreme obesity. All these decrease the compliance of the respiratory system as a whole. So we have compliance of the lungs and we have compliance of the chest wall. Compliance of the respiratory system of the whole depends on the compliance of both of these. Okay. So both should be normal. Any disease affecting any compliance of these, it will cause decrease in compliance of the respiratory system. Then we have pleural effusion, pneumothorax. They are going to compress the alveoli and they are going to prevent the expansion of the alveoli. So that was about the concept of the respiratory failure. Moving on to the diagnosis and some important parameters which help us in determining the cause of the respiratory failure. So since the person is going into respiratory failure, we will see compensatory changes, that is increase in the respiratory rate, except in case of the hypoventilation, especially if there is decrease in the CNS drive to respiration. Then we will see use of accessory muscles of respiration, again because of the compensatory changes. Because of hypoxia and hypercapnia, there will be altered mental status. Central cyanosis will be present, which occurs in case of hypoxemia. If hypoxia cause is decrease in partial pressure of oxygen, then central cyanosis occurs. Then we can have a high volume pulse because of hypercarbia. Hypercarbia causes vasodilation, so that leads to high volume pulse. Then if we look for saturation of hemoglobin by pulse oximetry, we will see that it is less than 90%. And in arterial blood gas analysis, we will see partial pressure of oxygen less than 60 mm mercury. Partial pressure of carbon dioxide can be normal or decreased also in case of type 1 respiratory failure. Because of the compensatory changes, increase in the ventilation, more carbon dioxide will be thrown out of the body. So partial pressure of carbon dioxide can be less also. And if partial pressure of carbon dioxide is more, then that means it is type 2 respiratory failure. Then we have to look for pH and the bicarbonate concentration as well. pH, yes, if partial pressure of carbon dioxide is more, pH will be less. By looking at bicarbonate, we can come to know whether this respiratory failure is acute or chronic. because if it is chronic, then there will be compensatory changes in the bicarbonate concentration. Because if pH is less, kidneys will try to compensate by generating more bicarbonate ions. So bicarbonate ions will increase. So we can know whether the respiratory failure is acute or chronic. Then there is a concept of alveolar arterial PO2 gradient. So this is basically, as the name indicates, alveolar arterial PO2 gradient. What we do, we take the alveolar partial pressure of oxygen, we take the arterial partial pressure of oxygen, and we subtract the arterial partial pressure of oxygen from alveolar partial pressure. So that is the gradient. Normally this gradient is approximately 10 to 15 millimeter mercury. In case FiO2 is less and in case of hypoventilation, this gradient remains normal despite hypoxia, because the air which is coming is less, but whatever is coming, it is crossing. So the gradient is maintained despite the hypoxia. Actually, both alveolar partial pressure of oxygen and arterial partial pressure of oxygen, both are less. So we have normal gradient. But in other causes, since ventilation is normal, since the air which is coming in the alveoli, it is normal, but still hypoxia is occurring, so gradient is increased. Okay, so this alveolar arterial partial pressure of oxygen gradient helps us in identifying the cause of the respiratory failure. And how to determine the alveolar partial pressure of oxygen? For that we use an equation where alveolar partial pressure of oxygen is equal to inhaled partial pressure of oxygen minus arterial partial pressure of carbon dioxide divided by the respiratory quotient. And to determine this inhaled partial pressure of oxygen, what we do? Fraction of inhaled oxygen, say suppose in atmosphere it is 21%, multiplied by the atmospheric partial pressure minus that of the water partial pressure. So this is 47 millimeter mercury. Okay, so this will give the partial pressure of inhaled oxygen if we are inhaling from the atmosphere. Suppose the person is put on ventilator and this FiO2 changes. In that case, the alveolar partial pressure of oxygen is going to change. So basically, in case of decreased FiO2 and hypoventilation, we have normal alveolar arterial gradient. In other causes, that is ventilation perfusion mismatching, diffusion defect, and if there is decreased blood flow to lungs, we have increased alveolar arterial gradient. And if we give oxygen therapy to the patient for the treatment, this oxygen therapy will be beneficial. It will benefit all causes except in case of shunting. That is mainly in case of the extrapulmonary shunting. In intrapulmonary shunting, maybe in some places shunt is there, in other places shunt is not there. So there it will be little bit helpful. But if there is extrapulmonary shunting, then hardly there will be improvement in arterial partial pressure of oxygen. So I hope you understood the pathophysiology of the respiratory failure and why different causes are leading to different types of respiratory failure. Thanks for watching the video. If you like it, do press the like button, do share the video with your friends, and do subscribe to the channel Physiology Open. Thank you.